morning. I am going to talk a little bit about comorbidities in the setting of MS, similar to talks that we've done in the past, but a little bit broader, I would say. So the first thing that I think we need to talk about is what is a comorbidity? Because I think that's a fancy long word that sometimes we think we understand, but it's important to think about all the different things that can be comorbidities. How can a comorbidity affect my MS? And we'll go through just, I would say, the tip of the iceberg with that. And then basically, what can we do? What are proactive ways that we can approach our comorbidities? And just looking through some of the questions that were submitted before our summit and some of the ones that have been submitted during the summit, I think this is probably the area where we'll spend the most of our time. So there's long been this idea that we think about what does the comprehensive care for a patient with MS entail? And there's often been, and this is probably an emphasis at least at earlier neurology appointments, of DMTs, DMTs, DMTs. What are we doing in terms of disease modifying medications? How do we get you on those? How do we maintain them? But we know that it's more than just DMTs. We know that doing good symptom control for lesions that have already developed is an important piece of it. And then the other thing is managing those comorbidities that come alongside with MS. And that's really where we're going to focus for the rest of this little session. So what is a comorbidity? So the fancy definition, the one taken straight from one of the dictionaries, is it refers to the presence of two or more health conditions or diseases in the same individual at the same time. These conditions may or may not be related to each other, but they can coexist and potentially interact. And I think this is where it becomes so important in our patients with MS, because we often think about, well, you see us in the neurology clinic, we talk about the MS, we talk about disease modification, we talk about symptom management, but what about everything else? Because you are not just your MS, as all of you know, and you have other things going on that interacts with your MS. So let's think about what are examples of comorbidities. And I stopped listing things here because I ran out of space and I didn't want it to be like 10-point font. But if we think about most common comorbidities, we think about some of these being things that are within our control, and some of these as being things that are outside of our control. So vascular disease, you heard Dr. Wolf briefly allude to this, but high blood pressure, high cholesterol, heart disease, diabetes, or even pre-diabetes are things where we can say, hey, I do everything I'm supposed to do, which is good diet, good exercise, but you might still have a genetic predisposition to some of these vascular diseases. Mental health, thinking about depression, anxiety. Of course, other neurologic conditions, probably the most common one that we see as a comorbidity is migraines, but that is not exclusive of other neurologic conditions. Infections, musculoskeletal conditions. As we age, arthritis tends to be one of those things, especially osteoarthritis, that comes into play. I'm thinking about chronic pain, other autoimmune conditions, other abnormalities like kidney disease, liver disease, sleep disorders, and of course, so much more. So one of the things, and I bet I will get almost every single head in here nodding in agreement, one of the things that I think has become one of the biggest pitfalls in modern medicine is the fact that everyone practices very much in silos, where it's, I go see you, you're my MS doc, and you deal with the MS, and then I go see my primary, and they're the ones dealing with my high blood pressure, and I go see my sleep doctor, and they're the ones dealing with my sleep apnea, and everyone's kind of practicing with their own individual buckets. And one of the things that becomes so hard is it's not really necessarily their own separate buckets, but this nice combination or almost Venn diagram with multiple facets that exist. And so this has long been recognized, and there was a recent publication that showed this, where comorbidities becomes an important part. So you've heard me say this about 6 different ways about how important it is to recognize what's going on and think about treating it appropriately. So how can a comorbidity affect my MS? I've listed probably the top 5 things I can think of, but of course there's multiple more. So thinking about delay in diagnosis, complicating treatment decisions, contributing to disease progression, amplifying symptoms that already exist from MS, and then medication interactions. So if we think about delay in diagnosis, this is something that I think is a big emphasis, especially because we know we've got highly effective treatment options that we can use on the market today. That delay in diagnosis is contributing to that lesion accumulation, which then we know has some role to play in progression or disease progression as time goes on. So things that we see in terms of delay in diagnosis, there was a really nice paper published about 10 years ago, but I would still say holds true today, where it talked about there was a lot of people, particularly women, that got diagnosed with anxiety. And oh, you're having the tingles, it's anxiety, and often led to a delay in the identification of symptoms, or even things like, oh, you've got neck pain and you've got a pinched nerve. That numbness and tingling in your arm and leg are from that pinched nerve. Or, oh, you've got high blood pressure, your blood pressure is too low, that's what's causing the dizziness, rather than identifying, hey, maybe there's something going on in the brain. So it's important to recognize that some of these things can present like MS, but they can also present like other things, or MS symptoms can present like something else causing that delay in diagnosis. Thinking about complications in treatment decisions, as you guys have heard most of us talk about throughout the beginning of the summit, you'll continue to hear as Dr. Alvarez goes into research updates. There's a lot of treatments available for MS, and they're not all made equal in terms of efficacy, but they're also not all made equal in terms of thinking about predisposition to side effects from it or what their side effects can be. So things that can complicate, or comorbidities that can complicate which treatments we decide to choose or when we switch to another treatment, are things like frequent infections. So probably the most common ones that we think about are upper respiratory type viral infections, or even things like urinary tract infections. For our patients that are less mobile, thinking about wounds or like sacral ulcers or pressure ulcers can also be a common infection that we think about. For comorbidities with high blood pressure and heart rhythm abnormalities, sometimes that leads us to say, hey, maybe there's some oral medications, particularly the S1P medicines, that maybe wouldn't be a good choice in that situation. Thinking about ambulatory status in those individuals that maybe are more sedentary because of weakness or balance issues related to their MS, or for whatever other reasons. There's, of course, some medications that we know, particularly thinking about some of our anti-CD20 therapies or B-cell therapies, that increase the risk of things like urinary tract infections. Family planning is a big, I wouldn't say necessarily a comorbidity, but an important piece that does kind of impact what treatments we choose. And then mental health conditions. I think Dr. Upchurch alluded to some of this with anxiety and depression. We know that the data that exists looking at anxiety and depression as a comorbidity in MS is that depending on the study you read, and some of it estimates up to 50% of patients with MS will have this. And one of the things that I think is really important to emphasize here is that there often used to be this idea of, well, I got diagnosed with this chronic debilitating neurologic condition, and that is why I'm depressed. And I would like to say for everyone, that is not true. So that might be a piece of it, but we also know there's other parts of it where we go, MS is affecting your brain. It's causing lesions and inflammation in your brain that's affecting the pathophysiology of what's going on in that brain. So is there some component of these two mental health conditions that's related to the sheer fact of MS happens in the brain? And I think that's an important point to emphasize, because there's sometimes among some generations and among some cultures where it's, if I'm depressed, I need to just get over it. And it's important to know that MS could directly be causing that depression without just causing depressing symptoms. We also know that some of the medications we use, primarily thinking about some of the older injectable therapies or platform therapies like interferons, might also have that risk of depression as a side effect too. And then I think Dr. Wolf also, which mentioned this really quickly when he was talking about some of the questions that had come up, but we know comorbidities can also affect how our MS progresses. So there was this study done, which I think still holds true, where they showed vascular disease. And if we think about my first couple slides, vascular disease again alludes to anything with high blood pressure, high cholesterol, or higher sugars, whether that's prediabetes or diabetes. We know that vascular disability or vascular disease is associated with a quicker onset of disability or quicker onset of progression. So when we look at this chart that I put up here, what they really saw was that people needed help walking, whether that was a cane or a walker, faster if they had a history of vascular disease compared to those with MS that did not. Okay. How does a comorbidity affect my MS? And I think this is probably one of the most important points where we say it can amplify symptoms that MS already causes. And if you guys have heard us talk ever, you know, all of us will always say just because you have MS doesn't mean you can't have something else. And that becomes so incredibly true. We talked about symptoms that can kind of overlap with the MS, leading to delays in diagnosis. But it's also true that you could have some MS symptoms from something else, and both of them amplify one another, causing to have an increased exaggeration in those symptoms and things that become a little bit more complicated to treat. So I'm going to focus on two main symptoms, which I think are commonly questions that we get asked about, and I know there were some questions that were submitted before the summit about them too, which is fatigue and cognition in this particular part. So fatigue based on, and I won't spend too much time on this because I know Dr. Upchurch just did a whole talk on it, but when we think about fatigue, some of the data has illustrated that about 85% of patients with MS will experience fatigue in some form. And for most of my patients, I've heard them say, well, I know what being tired feels like. My fatigue from my MS is not just being tired, it's more, it's something different, right? And so when we think about, okay, we've got this component where we think about fatigue, and I think it makes a lot of sense when you think about it. And for those of you that have heard this analogy before, I apologize. But if we say, hey, if I have one main pathway that helps me open and close my hand, and I get a lesion right in the middle of that pathway, what I'm doing is I'm invoking the use of additional pathways to do the same action, right? So I'm therefore using more energy, more pathways to do the same action. So it makes sense that everyday actions that maybe didn't make me feel fatigued before I had that lesion, before I had this diagnosis, now does, right? The other things that we know amplify this is medication side effects. MS patients can have a lot of symptoms related to lesions that exist, and almost every single medicine we use has fatigue listed as a side effect, plus medicines for everything else. And so it becomes really hard because you go, how much of this is from these medicines I'm taking? How much of this is from the disease? How much of this is I'm already fatigued because of my MS, plus I'm adding on these medicines that would make someone that doesn't have MS already feel groggy or drowsy? Chronic pain, we know, has a huge role to play in fatigue. And this doesn't have to be just neuropathic pain related to MS, but it can also be pain from, hey, I'm walking abnormally because of my MS, so now I've got chronic back pain, and that's also contributing. Other medical diagnoses that can contribute to fatigue include low vitamin B12 and thyroid disorders, which having MS doesn't necessarily cause you to have low vitamin B12, but if you have that, it can amplify some of these symptoms. And then sleep disorders, which is one of my favorite things to talk about because sleep is so, so important for all of us functioning the way that we are. And I say this with a 6-month-old at home who is not sleeping, so forgive me if I'm rambling ever at a point. So when we think about sleep disorders, we go through different phases of sleep, right, when we're sleeping. And probably the one that's the most important is REM sleep, or that kind of restorative sleep. And the way to think about REM sleep is this idea of saying our brain is a muscle, albeit a very complicated muscle, but it's still a muscle that needs to rest. And it gets that rest, it kind of clears out the gunk we accumulate just from being awake and engaging with the world during REM sleep. Now, the hard part with REM sleep is you don't go to sleep and then go automatically into REM. If you do, it's a different sleep disorder. But what should happen is you go through different cycles. You hit your first cycle of REM sleep after being asleep for about 90 minutes or so. The longer you are asleep, the more REM cycles you accumulate, which you can kind of see on these pictures where you go, okay, my REM cycles are getting longer and more frequent the longer I've been asleep. The kicker here is if you wake up, let's say, gosh, okay, I got 2 hours of sleep and I wake up right here, you don't pick up where you left off, you start again at 0. So in individuals that are going, I'm waking up frequently because I have to use the bathroom because my bladder is doing all these things from my MS, guess what? We're probably not getting to those hours 5, 6, 7, 8 where you are getting good solid REM cycles. So what do we do about it? I think it's important to, one, be aware of it, and then two, kind of say, well, hey, I want everyone to feel empowered, saying, if I feel fatigue from MS, it's hard because we've got some treatments for it. They're good, but they're not necessarily fixing it, right? But what can we fix? If there's something like the bladder that's waking us up at night, can we work on things to address that? We sure can. The other thing I think that's important to note too is just sleep pathology like sleep apnea. So we think about sleep apnea happening in about 3% of the American population, but we know it happens at a much higher frequency in patients with MS. And there's two different kinds of sleep apnea that we kind of generally talk about. There's one called central sleep apnea, which is, hey, the brain is not triggering me to breathe. And then there's also obstructive sleep apnea, which is there's something here that's physically impairing my ability to breathe while I'm sleeping. And we see both of those at higher rates in the MS population. And this is just an illustration of the difference between the two. And why does that happen? I don't think anyone really quite knows. Is it because there's brainstem lesions? Potentially. Although, do I see patients that have apnea in the absence of brainstem lesions? Is it because there's a body habitus issue where we go, hey, we're more sedentary, we're not able to move around as much, and that's creating some of this increased neck girth that's contributing to obstructive sleep apnea? Maybe. Is it some medicine side effects? Maybe. But that all being said, it doesn't necessarily matter why. We know we see it. So when should you, if you're not talking about it with your doctor, when should you be concerned? Hey, is there something going on that's apnea related? And often if you have someone that shares a bed with you, they might be going, ooh, you're snoring a lot. Or I'm hearing you stop breathing for a little bit. It's kind of freaking me out and I'm trying to wake you up. That's probably thing one that we should say, hey, that's something you should get tested for. Other symptoms that we kind of think about is if I get 8 hours of sleep and I'm waking up and I don't feel like I got a good night's rest, and I wasn't waking up multiple times overnight, then maybe that's something I should think about my sleep pathology just not working properly. So unrefreshing sleep, fatigue that is present from the moment of awakening, morning migraines, or even middle of the night migraines, snoring. And then we use this thing called the Mallampati score, which is when you open your mouth that we can't see as much of your uvula, which is the thing hanging in the back of your throat, and we can't see as much of your palate. I'm going to shift just to cognition real briefly. So we think about cognition having some sort of impact in about 2/3, so the majority of our MS patients as well. And cognition is a very, very complicated thing where we go, is it cognition of, ooh, I've got a word on the tip of my tongue, but I can't think of what that is? Or is it cognition like, I can't remember close family members' names that I should remember? So things that can affect cognition, things that are important to pay attention to. We already kind of talked about sleep and how important sleep is with that, but medication side effects too. There's lots of medicines where I hear people say, God, that made me feel kind of like, more sedated, and I wasn't able to think of the words I wanted to say, or that just made me feel kind of dumb. Depression and mental health is a really important piece that comes into cognition. So there's this idea of something called pseudo-dementia, where if we look at someone, for all intents and purposes, they kind of look like they almost have like an Alzheimer's type dementia. But the interesting part with that is they don't have the typical protein tangles or the plaques that we kind of think about in the brain associated with Alzheimer's. And we can see depression showing up the same way as Alzheimer's, but instead the treatment is if you treat the depression, then the memory issues get better. So focusing on mood and depression, not necessarily just to help with the sadness feeling, right, which is one piece of it, but it can show up in a lot of different ways that I think we still don't fully totally understand. And of course, stress makes no one's brain work well. So that's another piece to pay attention to as well. How does my comorbidity also affect my MS? The last one I'll talk about is just medicine interactions. And a lot of these, for example, when we're choosing a disease-modifying therapy or the interaction it has there, I won't focus as much there because these are important conversations for you to be having with your doctor, where you're kind of thinking about immunosuppression can affect that, or some of the other medicines I'm taking, like if I'm taking a medicine for helping with clots like warfarin, like a blood thinning medicine, sometimes teriflunomide or Aubagio can affect that. And there's other interactions, which I will skip for right now, because again, those are things that are directly related to, or directly discussions with your doctor. These are other medicines that I would bring up that are important to pay attention to. If you're on symptomatic medicines, probably the one that I think is important is thinking about modafinil, which we've heard about being used for MS, can sometimes decrease the frequency of how well oral contraceptives work. Of course, any medication that's going to cause sedation, like antispasmodics like baclofen, tizanidine, gabapentin, pregabalin, or Lyrica, can interact with other sedating medicines to amplify that. And then, of course, thinking about some of the other medicines that we use, like Tegretol and Trileptal, which is that last bullet point, can affect some of the other blood thinners or antidepressants that we use. But here's where we say, what do I take away from this? I've told you all the different ways comorbidities affect your MS, but how are we proactive about this? What can we actually do? And I know MS sometimes feels like, well, it's a lot of just doctors being like, here's things, but what can you actually take from it? So comorbidity management is a huge, huge piece of kind of that proactive stance. So you will hear us often say it's important to see your primary care doctor, even if there's not anything going on, because what you want to do is identify some of these comorbidities, right? Most people with high blood pressure don't feel high blood pressure until it's really, really high. So following regularly with your primary care, making sure we're not missing things along the way that can worsen our MS. Making sure you're updating your team of doctors, your team of neurologists, what is changing so we can make sure we're adjusting symptomatic medicines and disease-modifying therapies appropriately, and then kind of thinking about optimal lifestyle management. And I'll go into what that is. But I think some of this is where you go, here's 100 different things she's going to say from a lifestyle standpoint, but picking and choosing where you can start, because all of it's great in theory, but if you do something, something's better than nothing. So thinking about the 3 areas where you need to stay active, you often will hear us talk about physically active, right? But thinking about cognitively active and staying socially active become just as important, especially when we look at some of the studies that talk about overall brain health. So physical health, the important thing to think about here is it's not one size fits all. Like, great if you can go running on a trail, that's fantastic, but that's not feasible for everybody, right? So we say within the confines of what MS has left me with, right? Within the confines of whatever symptoms I have with MS, how do I make sure I remain as physically active as I can? Probably one of my most favorite activities is thinking about water therapies, which Michelle Harrison has a nice hydrotherapy class, but it doesn't necessarily need to be that. But anything where you go, okay, I can go in the water and I'm not as worried about falling over. So if I've got balance issues with my MS, that's something where you don't have to worry about it as much. And then you're also not fighting gravity. So the sheer act of just moving the legs around in the water becomes a lot easier because you've got the buoyancy of the water to help you. So kind of thinking about, well, what can I do that allows me to work on my physical activity strength, again, within the confines of where I am? Physical therapy can be incredibly helpful too. It's saying, here's your exam. What else can I do? Balance activities also is a really important piece of all of this because everyone's balance gets worse as we age. That's regardless of whether you have MS or not. So focusing in on balance is also a key component. Cognitively active, picking up a hobby that you didn't already have. So things that are best is new languages. So Duolingo, where you go, I'm doing a couple minutes of a new language every day, but it doesn't feel super intense where I'm not able to meaningfully do something like that. Picking up new hobbies. Instruments are also really good for cognition. And then remaining socially active. There's been some studies showing that being less socially active increases risk of depression and cognitive impairment and Alzheimer's as time goes on. Diet, I don't think there's anything new in terms of diet, but kind of thinking about the Mediterranean diet as the diet that's got the best data behind it. But really eating with common sense becomes important. So you're not eating Oreos for dinner. And then, of course, we've talked about sleep, but then emotional well-being is also very important. Thinking about good stress, I feel stressed because I'm doing this exercise, but it's a good stress as opposed to I'm stressed because I'm taking on more than maybe I can handle right now. So kind of thinking about energy conservation as well. Okay, and I will end it right there. So thank you for your attention.